Thank you very much for that, Jeffrey. It's wonderful, isn't it? If ever your children ask you what do you think they should have as a career, always say a health economist. They're like hen's teeth. It's extraordinary. It is the profession. That and bioinformatics. That's my career advice, right? If you want to be kept in the style to which you'd like to become accustomed, that's the thing to get your children to do. Okay, so we're going to go for, we're having a panel discussion now. So I want to call up, and there's a changing cast list here. So it's Munir, it's Annika, Nadine Qureshi, Rachel Butler from Southwest TFC, Jeffrey, Phil Evans, and Phil Jennings I've got here. They all have to squeeze up. So, challenges and opportunities. So, what I want to do is just go down the line, and because we're going to be positive today, ladies and gentlemen, I want you to start with one cracking opportunity, which is going to make it really hard for Nadeem, because he's got to think up a new one by the time everyone's said theirs. Okay, let's start with you.
I'm Phil Evans. I've been up here before, so I'm the National Specialty Lead for Primary Care for the Clinical Research Network, and I'm a GP as well. I think it's a challenge, Vivienne, was that right?
No, opportunity.
Opportunity, sorry. My cup must be half empty. No, I think the opportunity is basically in general practice and primary care, as we were saying, the opportunity to actually stop adverse drug reactions and prevent really serious adverse drug reactions. Implementing that is another matter, but I think there's a vast panoply of conditions we could be working on.
Now I'm going to call you Phil too, for the purposes of this. Simply nothing about his qualities, just happens the order they're sitting. Phil Jennings.
Thanks, Viv. I've been called worse. It's okay. I'm Phil Jennings. I'm also a GP, and I'm the medical director of the Innovation Agency, which is one of the academic health science networks in the North West Coast. So, again, as a GP, I think there's incredible potential, and I think that lies in the data that we hold in general practice. So we've all held computer records well over a decade now, and those records are by and large, they're pretty good quality. We code the patients ourselves, so we're not reliant on coders. And also we've got QOF, which is a mechanism by how we get paid. And GPs get really grumpy if they don't get paid properly, so we make sure our records are pretty accurate and pretty well coded. That's not well tapped, but that may be a challenge. But the opportunity is there. We've got a fantastic data set, and that's a mine that we need to take advantage of.
Jeffrey.
I think the opportunity is in realising the potential of pharmacogenetics and personalised medicine. And if the estimates are correct in terms of the incidence of adverse drug reactions and how they are related to pharmacogenetics, then prevention of even a fraction of those, I think will have tremendous implications on patient safety.
And presumably cost, since you're a health economist.
It's cost saving, of course.
Cost saving, of course. Your top opportunity.
Thank you. So I'm a clinical pharmacologist, and there's more than one of us in the room. So I am interested in prescribing and how do you prescribe safely and effectively. And at the moment when I prescribe, I take into account age, concomitant medications, renal function, liver function, but I don't take genetics into account. And this is the sort of opportunity whereby we can actually bring that together and try to improve prescribing even more so than we can do at the moment in terms of the educational resources there are out there for prescribing.
Opportunity for you, Annika.
I think it's about building on all of the experience and knowledge gained in developing educational resources and making sure that we actually get a really good suite of educational resources to support the pharmacogenetics, pharmacogenomics agenda.
Rachel.
Okay, I'm Rachael Butler. I'm a clinical scientist. I'm the lead of one of the new genomic laboratory hubs. I think the opportunity is to build upon the work of the 100,000 Genomes project. We've already built fantastic laboratory facilities, so we're halfway there. So we can build upon that, use our genomic facilities to actually deliver this kind of testing really quite, I don't want to call it easy, it won't be easy, but to deliver this testing, and most importantly, to then hold the data and then compare it to the clinical data and maybe then find new pharmacogenomic targets.
Hi, I'm going to confuse you a bit here, because Munir says speak for about 2 minutes. That's why that strange slide's up there. So if I can just deviate slightly. So I'm a GP, as you heard earlier, but I'm talking here as a primary care health service researcher. And in terms of implementation, if you look at the work of people from UCL like Sue Mackey and Elizabeth Murray, big areas are capability within the person, motivation to change, and opportunities. And what we do when we try to implement these changes is look at the barriers and facilitators. And we often find there's many barriers, but often there's a single sweet spot that's a critical barrier. For instance, in capability, time for GPs. In studies, we've actually, to help with time for GPs, if we get a positive genetic test, we've set up referral mechanisms so they don't have to worry. In terms of opportunities, you have to deal with the politics of the area. So if your pathway doesn't fit in with the pathway in the area, pre-implementation, you need to change that. So sorry, it's a deviation, but explains what's up there.
So, can I just put it to you as well, that as far as opportunities go, that the public may be further ahead on this than the health service. So the public kind of get this stuff straight away. Pharmacogenomics is the easy bit of genomics as far as the public is concerned. Because if you talk to, we've just done a big piece of dialogue work with the 100,000 Genomes Project, and people are very enthusiastic, and the pharmacogenomics bit they get straight away and can't think why people aren't doing it already. Is that going to be a challenge? I'm looking at Annika in terms of an education mismatch, or an enthusiasm on the one side and a workforce on the other hand that is not skilled up to the required level.
Well, I think we could try and turn it into an opportunity rather than a challenge. And I think we need to work, we've talked a little bit earlier on in the day about engaging with the patients and public much more, and working with them around developing educational information and resources for them so that they're informed as well. I think, as you say, that there's a demand from patients and the public for this work, and I think as we are starting to implement pharmacogenomics, we'll catch up. So I don't know from others, perhaps they see it more as a challenge.
Have you, Phil, have you had people...
Can we manage it?
Yeah.
So I would say that, yes, if I said to a patient, can I offer you a test to see if this drug would work, they would readily say sure. But what I don't do is say to the patients, further to Munir's talk earlier today, when I'm prescribing their statins or whatever, actually there's only about half a chance that this is going to work anyway. And I've got a hard enough time getting the patients to take their statins as it is. I don't think that we've really addressed that as clinicians yet, let alone ready for the public. And I think if that narrative was started to play out in the Daily Mail or whatever, we would have a huge challenge on our hands. So maybe the profession and clinicians need to start to get more honest with ourselves in terms of how we're going to change our prescribing practice and behaviour before we move on to the public, because I don't really think we're ready for it right now.
Anyone would like to expand on that? It's an interesting point. Nadeem.
I wish you hadn't brought up about the statins. It's the problem is, I think, is the expectation of the public that actually you say this will make it better, and when it doesn't make it better, but you said it will make it better. So it's actually being honest and realistic. So this is nothing to do with genomics. It's to do with contraceptive advice. Several GPs, you must have gone on the John Guillebaud course about contraception. And I find his pictures wonderful about, look, your risk on the contraceptives this compared to flying a plane. So we have to give them a sense of what the actual risk
are. Can you get pregnant while flying a plane?
No, you can, it depends what you do. But yeah, so it's actually about giving it in a language that's clear and that doesn't disappoint.
Any thoughts from you about that? Nikki, there was a big harumph from you there.
No, I was just agreeing with her. chest infection, but I think one of the important things, and this was, sorry. This was raised recently. I'm now in a commissioning role, unusually, and this was raised at the clinical commissioning group, is that one of the challenges that the pharmacists face is not just trying to sort out the medication that the patients are on with the individual pharmacists in the GP practices, is the fact that people only 50% of the patients take their medication at any one time. So would you then perhaps have a motivated group if you were talking to people about specifically testing them, or saying, when you, Phil number 2, when you said it's hard enough getting them to take the medication in the first place, you'd be talking, would you not, to a motivated group if you were starting to talk about genomic testing, so you'd have a better uptake anyway in that group?
So you've got this drug. It's perfect for you, Mrs. Smith. Absolutely perfect for you.
Yeah, I mean, I think we've mentioned before that there is a risk of widening an inequality gap. And I think whenever we introduce new technologies or new pathways, it's always the more educated, affluent, motivated group that tends to benefit, and we often inadvertently widen health inequalities through that kind of work.
Munir.
So adherence is a major issue, obviously, and I think there is one example of statin use and doing a pharmacogenetic test. And the study was done in Duke. And when they did that study, and they informed half the patients that they'd had this pharmacogenetic test, and they didn't have the variant, and then they also did usual clinical practice, what they found that the rate of adherence was greater in those who had had the genetic test, because they were told they didn't have the variant, which would increase the risk of side effects. So it can act in a positive manner as well in terms of improving adherence. And I think we talk about personalized medicine, we talk about genetic testing. I think personalized medicine will succeed in its own right if you improve the conversation between the healthcare professional and the patient, irrespective of the genetic test you do, because they need to understand what the benefits and risks are of the medicines. And when I prescribe drugs to my patients, I say, look, I do not know whether this is going to work first time. If it doesn't, I'll keep on assessing you, and I'll change you to second drug. But if I can say that, with the genetic test, it's going to work to a greater extent than it would have done without the genetic test, I think that's a positive message.
And to pick up on your point, the converse could be true. If you think of the Daily Mail headlines, and I'm an ex-tabloid hack, but you think of the Daily Mail headlines, and actually there are already lots of headlines about drugs don't work, pharmaceutical companies have been kidding us all this time for drugs that don't work, and that could be an unfortunate side effect.
Yes. Well, I think it's broader than that, because I think there's a trust element with doctor-patients. I think a lot of the effectiveness and the value of primary care is built upon a relationship of trust. And again, if we know that we're not maybe being as transparent with our patients in terms of what we think these drugs are likely to achieve, ultimately that risks undermining that trust moving forward, and that's a real problem for us.
Different.
Yeah, it's a complicated issue, because the numbers needed to treat for most medicines, it's in the double digits, if not greater. So most people are not going to benefit from the treatment that they receive.
And that's we've kept that pretty much to ourselves, have we not? In the medical
Indeed. But then if through use of personalised medicine you could identify those most likely to respond, then the NNT comes down, and then that might be a positive feedback in terms of them wanting to adhere to treatment, as Munir's already illustrated. So, but that would be in the context perhaps more in terms of pharmacogenetics that can predict response to treatment and efficacy, as opposed perhaps to the avoidance of adverse drug reactions. So there's subtleties in different directions here.
Before we go too much into the challenges, any opportunities that we've missed that you would like to contribute?
Just one thing. If we are giving people drugs that we think have a greater idea of working, we can reduce the amount of drugs we're giving, especially to patients who have many comorbidities. Then you would up the amount of drugs that they take. Some of the older people, I'm thinking of my parents now, they literally put their tablets around their plates. If you can sort of take 20% of them off, It's got to be a win-win situation.
Or they start doing what my mother used to do, which is, oh, I think I'll have one of the pink ones today. I'm feeling like that today. Yeah.
That's absolutely correct, because many of the patients I see are on more than 10 drugs, sometimes 15 drugs, and adherence is a major issue. But I think one of the things that we don't do very well is deprescribe, stop drugs. I think that genetics, if we start thinking outside the box with regard to pharmacogenetics, and we will never be able to carry out randomized controlled trials on this, where this is where real-world evidence will be important, is that sometimes pharmacogenetics may help us to decide which drug to stop as well, so that you can actually reduce the burden as well as giving them more effective drugs, but also stopping certain drugs as well.
Okay, another opportunity there.
Sorry, I just wanted to have you're saying that I've heard twice now that there's no way we can do randomized controlled trials. Is that really true? I mean, panel testing, trying to evaluate absolutely every variant that you're looking for, would be difficult to do in a randomized controlled trial. But if you have something that's very prevalent, like clopidogrel resistance, you could do a randomized controlled trial, and you could have secondary outcomes looking at the other gene drug targets as well for all those patients who may be on a number of drugs.
Sorry, so I didn't say you can't do randomized controlled trials at all. Even with the Bacavir, they were able to do randomized controlled trial with 5701. And there are trials going on with clopidogrel and CYP2C19 at the moment. What is more difficult is when you have a large panel, and how do you incorporate that within a randomized controlled trial? And you could do cluster randomized controlled trials or step wedge design, so there's very different designs you can undertake. The problem is that you end up with a very large sample size. It becomes really expensive to do the randomized controlled trial, and the funding agencies will say, well, these are all generic drugs, and if you're going to do this, this is going to cost a huge amount of money, and we can't see the benefit of doing something like this. But when you come to the rare adverse events, it's actually very difficult to do randomized controlled trial on an adverse drug reaction, which occurs in 1 in 10,000 people. So I think there are sort of,
Yeah, and I'm thinking about drug efficacy. I'm thinking about drug efficacy because for that
absolutely.
We've got an awful lot more patients. To be thinking about.
Absolutely. And clopidogrel is an example where people are doing randomized controlled trials on that. But I think we will need to use that plus real-world evidence as well. I think we need to use all evidence in a very sort of coherent, intelligent manner, rather than saying, well, actually, this is observational data, it's all rubbish, we'll just throw that away. And randomized controlled trials are the gold standard. Actually, randomized controlled trials also have their own problems as well.
We do have to be able to show, don't we, in the end, that it's actually working.
Yeah.
Okay, let's turn. We've had our blast of positivity and optimism. Let's go for the challenges. I'm going to start with you, Nadeem.
Oh, okay. Right. So if I go back to the scribe up there, if I talk from a primary care practitioner's point, is the capability to do this. And all of us, 10 minutes is not enough time to look at 2 diseases, let alone at the pharmacogenomics. So it's actually, before we even implement, we need to have systems in place to facilitate that. And I always think we've got linked prescribing with local pharmacies, so there should be a joint effort here. So it's the capability is one of the big issues for me.
Okay, just describe for me, if you had a magic wand, how would you see that new system working? You said jointly, a kind of co-production with pharmacists.
All right, yeah.
Just give us your ideal.
Well, like in Sweden, how there's little chips in their arms. So no, but what it is that you do need patient-held records to do this. I think you need patient-held records either on phone or on a credit card or whatever, so they actually have the information themselves, and you empower the patient to take it. It's similar to that 23andMe incident with anaesthetists. The patient should be empowered to say, look, this is what I've got, this is a doctor, and they can plug it into their system and say, oh yeah, I see how that works. You have to make it easily usable by all involved.
Can I just, a point of information here, is there yet a place on the electronic health record for pharmacogenomics?
No, that was what I was going to say. Was one of the challenge is at the moment that's not happening, so we can't record pharmacogenomic variants in the electronic health record in primary care.
So if I wander into you with my 23andMe result, what do you say?
Well, I've been stumped, I think. And when we talk to GPs generally, they glaze over at that stage. And so I would have to make lots of individual notes on the record that keep flagging up every time. So getting anything specific, so when the patient wants to have allopurinol, you'd have to look through 101 variants that I've recorded, rather than the clinical decision support system flashing up saying, this patient has this HLA variant, be careful, or their ethnicity is X, be careful. I feel that's possible, but we're way away from that.
Yeah, and also, would you have a view about who had done the testing? In other words, 23andMe, we know for whether you like them or not, that actually what they do is pretty accurate. But there are an awful lot of companies springing up, and not all of them may have the same standards. Rachel?
I actually think this leads in quite nicely to my challenge. So I'd say our challenge as laboratories is to ensure that we have absolute standards across the NHS. All laboratories will report exactly the same thing. So if they find the same variant, whether it's in Newcastle or Manchester or in Bristol, you would get the same report. And that report doesn't just report back an allele, so a variant in a particular gene, but it goes a lot further than that. And it will actually tell you, because we've detected this variant, that means this for your patient. But we're going to have to do a lot of work to actually get to that position. And it's work that we are doing with Genomics England's help and through our working groups, so that we give you a full interpretation. Now, we're not trying to do your jobs for you, but at least we should be able to say, because we found this genetic variant for a patient who's presenting with whatever, we would recommend that a dose is reduced by whatever. Because I think you're not going to be able to look up that kind of information in your 10-minute appointment, but that's got to be standardised.
Yes. So, Munir, I mean, there's always a thing about there not being enough clinical pharmacologists, another rare breed in the NHS. So, actually, that is a key point. It also goes to Annika about genomic literacy. And, education is not going to take us there. Some of it is just going to have to be, this is what you do next.
Absolutely. So I think, while Nadeem has 10 minutes as a GP to see a patient, as a hospital consultant, I have 20 minutes. And, there's no way you can incorporate all that information in 20 minutes and be able to do that manually. So I think the critical issue, and we do need to start working with companies that are developing this, is to have intelligent decision support systems, which not only take into account the genetics, because genetics is not everything. They take into account the renal function, the liver function, what other drugs you're taking, etc., and produce a holistic picture which gives you the sort of right decision right there on a pop-up screen, which you can't switch off. And I think that's going to be really important. The other thing about, somebody asked about machine learning, I really think the future intelligent decision support systems will be able to learn how the prescriber works as well. So really personalize the kind of alerts that they get. I think that's going to be really important as we move forward. And that is a challenge to develop something like that.
I was just thinking, personalisation to the prescriber. Oh, not you again.
Yeah.
Okay, there's a question up there.
I think the panel's brought up the very important point that we need joined up records, and we secondary care is way behind primary care in this. We can't, at the moment, we can't even tell between the two sectors what medicines the person's taking, what recent changes have been made, what allergies they already have that we know about. So that must come as before anything else. That's absolutely essential. And other countries do this. Spain, for example, anyone can access these with the permission of the patient and find out what they're on. Once we've got that, then all of these other things can be built in, because going back to the point, if we know the profile, and in secondary care we don't know what that profile is, then we're very negligent.
I should say that's a critical part of the NHS long-term plan, actually, to have that connectivity.
But also, there's maybe, I'll take a question in a second, but there's also a point about, we're developing the NHS app, which, as far as I understand it, I mean, who knows, but the NHS app seems to be the kind of the foundation stone, and then there will be all sorts of other plug-in apps that go around it, depending on people's particular conditions. But it would seem that, if people can have something that's on their phone that says any time you get a drug, just show the doc your phone, actually, that's pretty powerful. You know, if people know, particularly if it's an adverse drug reaction, that they shouldn't have something.
But the capacity is there already. I have my general practice app for my own patient care on my phone that's downloaded from System 1. So I can have drugs and adverse effects, so it is available, but we don't integrate it. That's the problem.
So one bit of the health system which is joined up and which is shared between, in the vast majority of the UK, is between on the laboratory side. So most of the pathology results are squirted out directly into primary care and feed into various hospital systems. So what I would like is to work with the new genome centres and make sure that the validated results that come from you are integrated properly into our laboratory system so that we can share that right across the board. Also, the patients then can access their own pathology results via most of the GP systems, and therefore they should be able to access their genomic information in the same way. So I think we really need to work together because historically most of the genetic results haven't come back through the routine laboratories. They've gone straight back to clinicians in many situations. So we have to make sure that that bit of the pathway is sorted out quite quickly.
And Rachel, actually that's where graphics come into play. And, you know, there are many ways of displaying information quickly and simply. And what it needs is those graphics to help people out, but also that there are standards for giving information that are the same across the entire system. Because it's all very well having, you know, a standard about variance, but if you don't have a standard about reporting and report it in different ways in different parts of the country, that again becomes extremely confusing.
I agree entirely, and again, this is a lot of work has gone on around this amongst the genomic laboratory community over the last year. So we now have standards around reporting for rare disease, standards around reporting for cancer, and I can see that we'll do exactly the same for pharmacogenomics. In fact, we've already have a report now for DPYD, which is our first pharmacogenomic test. But I agree entirely with the gentleman's comment that genetics hasn't been something that's been reported widely at all. It's had its own systems, different systems across the entire UK, and that's time that we put that right, so genetic results are freely available.
See, the one that we get, and which is really helpful, is hemochromatosis. It comes through the system, and it's very helpful, although sometimes people can't interpret it, but it is helpful.
Yeah, and also you need something that actually says to the GP, this is what you need to do next. But also for the patient, this is what you should expect to happen.
I think one of the other things that we need to consider at this end, before we've done too much, is the process of updating results. Because every time you look at PharmGKB, there's a star allele definition that's changed or a prescribing recommendation that's changed. And I would have a concern with patients wandering around with ancient reports that say, you know, take this dose of this drug, because that is something that's going to change. And if this is rolled out on a population basis, we need some way of updating this. So GPs, secondary care physicians, pharmacists are not working on what are essentially outdated recommendations.
But that should update itself if we have the technology with phones. Okay, sorry, Nikki again.
Just a quickie. Just going back to, potentially, this is a patient question. I'm going to pretend to be a patient in this situation. I'm chuffed to bits because I can now access, Nigel's made a very good point about pathology results coming through, and we know that genetic results come through differently. As a patient, I get a genetic result, which I'm, again, really chuffed that I can actually access it. But first of all, it says something quite, you know, the interpretation is really challenging. I think I would understand it now done the genomics masters, but as a patient I wouldn't. And it rings alarm bells for me. It might be something so significant, I really need to have had that result from explained to me by a genetic counsellor. What do we do in that situation, please?
Okay. Rachel,
okay.
One for you.
Well, this is the reason why genomic results have always gone via clinical genetics or a genetic counsellor, or these days through other clinicians who are now trained to give genetic results. So this is the reason why genetic results have not gone direct to patients. and why we're trying to work on our genetic reports to ensure that they are safe for patients or appropriate to be given to patients.
But Rachel, can I challenge that? Because, you know, when genetics is returning a relatively small proportion of results, that's perhaps doable. But when it gets to be, you know, I think Mark will have probably told you this morning, you know, 80% of the people who came into 100,000 have a, you know, an actionable item on their pharmacogenomics. You know, that's a huge number of people. So don't we have to think of systems where perhaps, you know, you're sent information as a patient, and then you go to some website where it says it gives a lot more information. There will always be people who want the personal touch, who have a particularly difficult thing that needs explaining. But it's not possible to get back to everybody. So there has to be a lower bar.
I agree entirely. I think we've been very protective in genetics for many years. Don't tell any of my colleagues I'm saying this.
It's recorded.
But, yes. Look at my face.
Nobody from genomics here.
Maybe Bill will come in as well. But I think we have, and it is time that we now started mainstreaming our services. And there are some cases and patients who very definitely need to come into clinical genetics. But there are some services and some tests in particular where the results, it's great that we are mainstreaming and other clinicians are looking after those tests. And maybe even some tests which will become point-of-care tests in the future. And pharmacogenetics is probably going to be some of those.
So you can think of So you can think of you as the Savile Row suit, but there also needs to be stuff sold at Marks and Spencer's.
There's Topshop too.
Topshop. Don't mention Topshop.
That's where Annika sort of comes in, because we need to have Topshop, and in terms of sort of maybe it's web based, but it's in terms of actually what is the quality of pre-test counselling that could be provided by non-specialists.
So can I just make a point about this genetic counsel? I really don't think we need genetic counsel for pharmacogenetics.
No.
Because if we do, then pharmacogenomics is dead, basically. I think what you do when you prescribe a drug is that you have to have a chat with the patient. Good medical practice dictates that you have a chat with the patient about what you're doing why you're prescribing that drug. You have to tell them about certain risks and benefits, and the genetic test is part of that. It's no different from what.
But also, if you're sent something and you've got a link then that you can just click straight through. Does anyone know the site mygenecouncil.com in the US? It's got some really, really good and useful information. And actually some of that will take people a long way, especially in pharmacogenomics, where, you know, it's not life-shattering news, but there will be still the Savile Row merchants to do the more difficult stuff. Right, so did you have you were apoplectic up there, so yes, just give us a rant.
Quite apoplectic, but certainly, in our lab, I'm sure it's true, it feels Rachel, that probably only about 15% of the results go back to a clinical geneticist. The vast majority of results are ordered and returned to specialists outside of clinical genetics. So they're going to paediatricians for all the arrays with learning disability, they're going to obstetricians doing tests during pregnancy, they're going to oncologists. We never see any of the somatic test results when you're testing cancer tissue. They all go back to the oncologist or the person that's taking the cancer tissue. So the difference, I think, is around whether you're using a genetic test in a diagnostic setting, where the patient's already got some symptoms and you're trying to find out the reason for that. And there, in the majority of cases, the clinician seeing the patient should be empowered to offer that testing, be they a neurologist or a renal physician or a cardiologist. I think that's really important that they can have some ownership of that. Where clinical genetics has got a real role is for those ultra-rare complex disorders, and also in terms of predictive testing, we've got a healthy person that needs some discussion about what will that result mean to them, and in predicting something that might happen to the future, in the future. Because I think there's a real complexity around that, which isn't captured in 10 minutes or 15 minutes of a consultation in most other medical specialties.
And when multiple family members are also involved.
Exactly.
That becomes really complicated.
Cascade testing is something that genetics has got some experience and some ability to do, which there isn't the resource in a lot of other areas of medicine to do that, or the infrastructure to do that. But I agree with Munir's point that if we start thinking that we need to introduce clinical genetic algorithms and approaches into how we adopt pharmacogenetics, will be absolutely something.
Yeah, and actually the public, the genie or the genome is already out the bottle, because they're already going off and doing those tests anyway, with Ancestry.com, and, I'm related to, what was Danny Dyer related to? Yes, Danny Dyer was related to royalty, I know that. But we're all related to Vikings. So there's several questions. Okay.
Just to actually build on that point, as particularly working with kids and thinking about sort of testing their genetic data, and they're going to grow up with all this wealth of information that we're meeting new, so partway through our lives, wherever that might be. As they grow up with it, they might be tested very early in life, as they first arrive into the world, whether it's to test for to make sure they don't get hearing loss, but then thinking about the patient journey as they go along, what that looks like as a patient journey, and knowing that they perhaps are susceptible to perhaps different medications or whatever they meet in life, and how that changes through their lifetime, and who takes ownership of that as they go on. Perhaps if they if they're not aware that they've had their genetic information used early in life, perhaps parents forgotten or lost touch or whatever, and what that looks like, I think that's a challenge that should be thought about in terms of both ethically testing children and also how it's used in the future.
And there's a challenge, which will be a Daily Mail headline. Whether you tell people whether they are more at risk of smoking because they're genetic variants, or they're more at risk of psychosis from cannabis. Discuss. No, don't discuss. Okay, question here.
It's just a comment or a question that if you have a private provider, like I get my genetic testing, do you think that it should become a part of my medical records? And if not, why not? Because this is my personal information. That's my personal medical record with the NHS. Why it should not become a part of the medical record?
Okay,
because
let's go to Phil 2 here, because I think you're looking sceptical here.
Well, no, I think you probably need to have a bit of counselling as to whether or not you want that as part of your...
I'm not asking for counselling. I'm saying the record, the genetic information provided by some provider outside the NHS, does that become a part? If I'm asking,
yes.
Okay, this is my information, can you add that to my medical record?
Well, it's your record. I think what I meant by counselling was that I think you just need to be aware what the implications might be from having that information there for
that's something
whoever to see at some point.
I need that. I'm a geneticist, I know that.
I don't think that it should be there without consent, if that's, I think. If that's
I think what you're saying is, you go to, I don't know, Myriad Genetics or something, they produce a test, you go into your GP, whack it down on the desk and say, put that on the record.
Put that on my record, so...
Munir, would you do that?
So I think that is going to be more and more important in the future.
Exactly.
And I think, but a couple of issues you need to consider. First of all, you need to make sure that the provider is producing something which is up to standard in terms of analytic validity. So that's number one. So if you're sure, and the NHS, let's say, has got this kite mark on that particular provider, then I think that should be included. But the way it's included, that's a challenge at the moment. And this is where we need the decision support systems, because it's, although I can get at the moment on our electronic lab records, I can get the factor V Leiden mutation testing, etc., HFE, hemochromatosis gene. I can't get many other things in there, including HLA. Sometimes I can't actually get on my electronic lab records for my patients. So I think we need to think about how, as we develop decision support systems and we develop the sort of electronic lab systems, how we incorporate genetics data, not only from genomics hubs, but also from external providers where you are sure of the analytic validity of that system.
Exactly, that's my point. We need to think about that now, rather than thinking after 5 years. we haven't heard about that.
Yeah.
And we are not planning anything.
Yeah, and some of them are not particularly good, and also you want to know what variants they're actually testing.
Yeah, but what you said, if you have a price more, then people know that, the patients will know that, public will know that. These are the providers which are approved by them.
I think that was one of the ideas behind Matt Hancock's genomics volunteer thing.
But one of my concerns here is it's about the inverse care law again. The people who can afford it will get it,
So I'm not arguing against that. Sorry, I'm not arguing against that, and we don't want to exacerbate health inequalities.
If somebody can get it, what's wrong with that?
Yeah, no, but it's just that if you look,
using taxpayers' money,
but if you look at Myriad when they introduced BRCA1 testing in the States, it was the high socioeconomic group that took it and actually used up the resources in genetic services. So it's just that it depends as a society what we want to do there.
Yeah.
And I suppose going back to try to illustrate Munir's point, recently we've had some really difficult problems with having diagnoses removed from records. So historical diagnoses of asthma or ADHD in 18-year-olds who had diagnoses who now want to join the army. It's not an easy process to have that removed from your medical record. So you just have to be clear what you're doing when you say, put that in my record. And it might be very easy for me to say, sure, yeah, there you go. But it has potential implications.
You're just talking about straight pharmacogenomics, so you're not. Yes, you're not. Phil won.
Well, I was just going to say, there is an argument. Sometimes it helps if you look at other things like radiology. We were chatting earlier about radiology. If you go off and have a chest X-ray around the corner from a validated extra radiologist, we put that in the record. That's just taken as read. So I think there's some principles from other areas that we could apply here.
Yeah, but there is an issue in disproportionate use of resources, as you say. Hello.
Oh, thank you. So I just wanted to ask, going back to your statement that GPs often don't have enough time to see the patients and that we lack very solid data from the sparsity of randomized control trials and all that. For example, as hospital pharmacists, we usually tend to provide recommendations to optimize medication doses based on renal function or liver function that's typically not evidence-based, but it's all based on pharmacokinetic equations or observational data. Going to pharmacogenetic optimization recommendations, for example, how likely do you think GPs or clinicians who are not experts in pharmacogenetics, how likely do you think they are to adopt such recommendations? And also, medico-legally speaking, who do you think has the ultimate responsibility as a prescriber to, after a decision has been made and the outcomes are affected in a way, let's say. So, and then also, for example, if we take the example of clopidogrel, for example, you have a 1 in 4 number needed to genotype, which can have actionable results, pharmacogenetic results. And that can affect your outcomes of secondary STEMIs and STEMIs. So if you switch someone to prasugrel and then they have another heart attack, will the patient be able to, for example, sue the practitioner or...
Okay, that's a very interesting point. So, okay, for you, where should the buck stop? Who should be the person with the ultimate responsibility?
I think it should be a shared responsibility between the final prescriber, whoever made the recommendation as an expert, and the lab.
Let's try the panel. Okay? Phil.
Well, yes, at the moment it lies with the prescriber legally. So that's the GP. So in primary care, so that's where the ultimate responsibility lies. So all of these things.
Should it lie there?
I think it should actually.
Okay.
Yep.
Phil too.
So all I would say is that we do need to acknowledge there's going to be a differing primary care workforce moving forward. Certainly general practice is largely doctor delivered. That's just not going to be the case for all kinds of reasons moving forward. So it may be that regulation needs to catch up with that to allow a broader range of professionals to safely prescribe through whatever mechanism. So in the future, I think we will have to embrace a change, and that may involve some risk, but that's a debate that we have to have professionally and with the public, I think.
Different.
I don't think it's a million miles away from the pharmacist, for instance, identifying an adverse drug interaction and recommending that one of the agents ought to be deprescribed in order to prevent that interaction occurring. And so the responsibility, likewise, if there was an adverse outcome regardless, because the condition wasn't managed appropriately, then there would be a clinical consequence of that. But it goes down to the shared responsibility that the prescriber and the pharmacist.
So we talked about multidisciplinary teams earlier today, and the decision of what to do will have to be driven by a multidisciplinary team, but the responsibility does lie with the prescriber in terms of you prescribe according to your competencies. And therefore, if you feel you're not competent, then you shouldn't be prescribing according to that. So,
okay. But what about if, let's say, the other side of that legal part is you haven't, or you've given somebody a drug, even though their pharmacogenetic report says very clearly that they shouldn't have it?
Then there are going to be problems, and there are some news reports coming through now from the United States where people had pharmacogenomic information and their doctors ignored it and prescribed them something, and they got adverse events, and they've taken them to court and have won.
Yeah.
So that legal issues are coming to the fore now with the wider availability of genomic information.
So that could either have a chilling effect on this whole field, or it could drive it very fast.
Yeah, and I think it will drive it very fast. I think the patient lobby is going to be really important driving this forward.
Okay, Nadeem.
Well, as everyone said, it's a final responsibility with the prescriber. But I think there needs to be collective ownership of the issue. And the thing is, we're talking about the future. I don't know, Munir might know, is we've had an MHRA warning about people of Southeast Asian ancestry and carbamazepine for 10 years, if not longer. But I'm just still worried, GPs, we don't do that. And has there been a litigation case? Because then the responsibility is there for us.
Do you want me to answer that?
I think we need to not be more afraid about genomics than any other test we do. When we think of the bad old days with HIV testing, we had to get counselling with a registered counsellor before we could do an HIV test, which meant that a lot of people had a delay.
You had to get counselling.
We had, even though I'm a doctor, I wasn't allowed to explain it. I had to get someone separately.
All right.
So it made the whole thing, number one, mysterious, number two, more frightening. And yet I could do a chest X-ray and then find out that someone had lung cancer and they were going to probably die within a few months. So we need to just normalise it probably and just embrace it along with everything else, the same responsibilities and risks as any other test we do.
And in that sense, the Ancestry.coms and all those kind of things have actually done quite a lot of the work in normalising. People think it's perfectly okay to do Ancestry.com and don't see it as frightening, even though they may have a child turn up on their doorstep, as far as I can see. Ancestry.com, which is quite alarming. Right, somebody up there.
I'm Joinup Shah. I'm also a clinical pharmacologist.
Hooray! How many clinical pharmacologists are there here? Oh, let's hear it for them. They don't often get a good press, but let's just give them a bit of love. Right. Now you're loved up.
So pharmacogenetics-based prescribing has lots of opportunities, but it does mean that clinical decisions are going to be more complex, and it's a lot of information for individual clinicians to be able to hold and use. So this is going to require a standardized information system and standardized data, but also standardized computable guidelines, so that you get the same decision support whether you're in the GP or in any hospital, because currently all the hospitals have different information systems. So I was wondering, should there be more of a role of national bodies such as NICE in creating guidelines in a computable form so that they can be standardized?
So we're talking, standardisation is something that's come up again and again as a challenge that needs to be overcome, whether it's the reports, whether it's in the variants that are being tested for by commercial companies, Munir, let's have you on this.
So I think there does need to be guidance and guidelines in terms of what we do with pharmacogenetic variants and what drugs you give and what dose you give. But what we should not be doing is reinventing the wheel. So there are already organizations out there which are producing these guidelines. The CPIC, which is an NIH-funded organization, and the Dutch Pharmacy Organization as well are producing guidelines. Where those guidelines aren't available, then we should be producing some guidelines and guidance. And one of the areas I was talking to Annika about is that they have fact sheets in terms of what they've been producing for rare diseases. For the sort of what NHS is considering in terms of implementation in the future, why don't we have the 50 gene drug pairs as 50 fact sheets that are available online for people to look at? And those can be dynamic and they can be updated as new evidence becomes available.
Munir, what about the patient who discovers that actually there isn't a treatment that works for them at all? Because that's the flip side. You can find stuff that works really well, but also you might be one of those unlucky buggers and nothing works.
Yeah, so I don't.
So now you're going to give me a drug that I know doesn't work.
So I don't think that any test, irrespective of pharmacogenetic or genetic or proteomic or whatever, is going to be 100% predictive. So if you do have a patient where you feel that there is a test which says it's not going to work and there's no other option available, you need to have a conversation with the patient and say, look, these are the potential issues. We have got a genetic test which is not going to work, but we can't be 100% sure. And I think for the disease you have, there's no other treatment available. I should still try it, and these are the risks and benefits, and follow you up to see whether it works.
I think the reverse is going to happen there as well, that you're going to have precision medicines which people will be denied because they don't have the particular variant, and they'll turn around and they say, what do you docs know anyway? It might work. And there'll be a big challenge. I predict that. Okay, so I think we've actually got to the end, and I've got to fly to California, so... So we have to stop it there. But will you thank the Phils, differing communities? Right.
Okay, so thank you everybody for coming today. I hope you found it really, really useful. The films of the talks will be ready in the next 10 days, I believe, and will be up on the Stratified Network's website. And just again, thank you for coming. Thank you for